Uh,
You do have a form, Dr. Thornberry.
Very good. Well, let's go ahead and get started. I have that it is 9:04 a.m. Today is November 4th, 2022. This is the Physician Technical Advisory Committee. We are meeting under auspices of Title 19. We do have a quorum. Let the record show that Dr. Tran, our Chairman Emeritus, Dr. Neal, and I are in attendance. The first item of business is the approval of the minutes from our last meeting. Is there a motion? They've been forwarded to you.
So moved, Dr. Neal.
I motion.
Very good. Is there any discussion? No discussion? All in favor? Very good. Thank you. Those
Aye.
are approved. We have no items for old business. We have new business today, and we've moved forward from our last meeting to this meeting, an item called recouping of reinvestments of services when patients retroactively disenrolled. Dr. Tran, I'd like you to set this up for us, please.
Yes, this has been brought to my attention by multiple clinic owners in the community, to include our clinic. And this is a situation whereby a Medicaid patient who is currently active based on the Medicaid portal receives services. And in many situations, these services are reimbursed by the MCOs. And months later, we will get a notice informing us that these patients were retroactively disenrolled, and therefore the reimbursements will be recouped. My understanding is that there are situations where many of these patients have somehow lost their enrollment status, either to incarceration or similar events. These are issues that are not shared with us, but regardless, I find it somewhat troublesome that if the portal states that the patient is actively enrolled and services are then rendered, could we talk about how we can remedy these situations in the future?
Thank you, Dr. Tran. So if I understand this correctly, the issue is patients come in from our view, and with their due diligence that we have, they are enrolled. They've been provided a service from us in good faith, and then retroactively a decision is made somewhere that the patient is going to be disenrolled or not enrolled, and they're asking for recoup of the reimbursement. Is that correct, sir?
That is correct, Dr. Thornberry.
Well, I'd like to be pretty fair-minded about this, and I try to take the view of both sides on this, but I don't see how in good business practice you can ask your partner to provide service in good faith and then let them do their due diligence and get a confirmation that the service should be provided, and then retroactively saying, well, by the way, we're just going to ask for money back. I'd have to ask what our MCO partners think about that. Did we have any of those people here, or is there anyone from DMS that would like to comment on this?
See, Leslie Hoffman is joining just now, so if you give her just a second, she should be able to address that.
No worries.
Leslie, are you on?
Go ahead.
So she's connected.
The ox is slow, but the earth
While
is
we're
patient.
waiting on Leslie Hoffman, this is Justin Derringer. I'm the with the Department for Medicaid Services Division of Healthcare Policy, and this is an issue that we were made aware of and that we are working on. It is a systems issue. We're working on that right now, trying to figure out how to make that work, how to fix that, how to remedy that. There are a lot of inner working parts and a lot of different issues that contribute to what's causing this problem that we're seeing. And one of the things we're also doing is in discussion with CMS, trying to figure out how we can, how we can make this work as well. We understand, how big this issue is. We understand that it's not a good business practice, that we have to fix it. We have to fix it quickly. and we're looking at ways to fix it on the IT part, while also in discussion with CMS to see, how can we make good on payments that when we tell somebody, a provider that this person's eligible, so it's okay to go ahead and provide services. And then later we're coming back and saying we're not. So we're having discussions with CMS on how we can make that right, because CMS says we can't pay for them if they weren't eligible. And we said, well, we said they were eligible at the time. So we're having some issues, but we've found some things in the programming. We found some things in the systems that are not right. And so we're making those adjustments. We're fixing those issues while at the same time looking at ways we can go back and try to kind of make that right. So we're aware of the issue. We're working on it. We have multiple people, multiple partners working on it. I don't know if anybody has any further updates than that, but I know we are meeting about it 2 to 3 times a week, and we have people working on it pretty much around the clock. So it's a big issue, and it's an issue that we want taken care of quickly.
Justin, I don't think we can ask more than that. If you're meeting 2-3 times a week on this. Dr. Tran, does that satisfy us from your view?
Yes.
Well, we
Yes,
appreciate that. Justin, thank you and your team for helping us with that. Cody, would you just make sure we hit that on the agenda so we can just gently see where we are next time on that one? Would that be okay?
Yeah, sure.
Yeah, thank you. I want to go ahead and move this because I don't want to belabor that point. Justin, thanks a lot. Our next operations position is 2023 Medicaid Managed Care Quality Outlook. We've gone through this. I appreciate DMS for providing this ahead of time. There were a couple of things that we wanted to chat about. Dr. Neal, could you expound on this a little bit? I have some things on my agenda, but I'd like to follow your lead here.
Well, yes, I'll be glad to. I received this a few weeks ago, and did all members of the committee get this document? It's like 85 pages. Did everybody get it and get a chance to look at it or not?
Yes, sir.
Oh, okay. All right. Well, it's as I understand it, and is there somebody on there from DMS that's prepared to talk about it or answer questions?
Sir.
Okay.
Yes,
okay.
sir. Dr. Neal, I'm Angie Parker with the Department of
Okay, Angie, great. Okay. Well, as I understand, you all are required to produce this document about every 3 years. Is that correct?
Yes, sir.
Okay. And it's a strategy for assessing and improving the quality of Medicaid managed care in Kentucky, right? Okay.
Yes, sir.
Well, it took me about 3 hours to read and reread it, and then I couldn't sleep for 2 nights after that because it really is a massive document. And the main thing troubling me about the document is that, as I understand it, and correct me if I'm wrong, but it was prepared after meeting and getting responses and interviews with many stakeholders.
Yes,
And
sir.
that was where part of my problem was, because it implied that both our committee and the MAC are people who were interviewed, and it named the people that were. I think Chuck was interviewed, and I think Ashima was interviewed also. But it didn't look to me like there was enough interviews of people that were, and not that you all aren't in the trenches, because you are, but I didn't see that any pediatricians were interviewed. I didn't see that people from Primary Care Association were interviewed unless they happened to be on the committee. So that was one of my main concerns. And it has a number of goals that I thought we could talk about, which are laudable goals. And one was to reduce substance abuse disorder and engage people there. 2 was to reduce the burden of outcomes of chronic diseases. Boy, that's a laudable thing if we could ever do that. Increase preventive service use, which also, because the social determinants of health are so important to our Kentuckians. 4th, and this was the main, was to promote access to quality care and reduce unnecessary spending. Now that's a big statement right there. And the 5th was to improve care and outcomes for children and adults, and certainly we're there. The main theme of this was, and it said that all stakeholders agreed that we need to migrate to quality-based reimbursement as critical to the evolution of Medicaid services. And I'd like to talk about that a bit, because that seems to be based on a theory that I think is misrepresented, and that is, with fee-for-service, we physicians, to make more money, just see more patients. And I would like some of the committee to discuss that, because nothing could be further. That is a misrepresentation of what happens. The reason Medicaid physicians for years have seen more patients wasn't to make more money. It was because they were beating our doors down to be seen. And I can assure you, the last thought in most of our mind was to see more patients to make more money, which actually is a laudable thing. But that's not what it's based on. And to change over to a value-based system where risk is taken, I think is a really bad idea. And I hear that discussed all over the country all the time. And I just think, I know it, particularly in pediatrics, I don't think it will ever fly. But I'd like us to have some discussion of that, because I don't understand why all stakeholders said that that's what we need to migrate to. I know that nationally, that seems to be what Medicare and everybody else wants to do. Can somebody comment on that? Chuck, or you, or Ashima, or somebody?
Well, let me, thank you, Dr. Neal. I would say from my seat as a rural independent primary care provider, I'll tell you, and having been trained by Toyota, as the committee knows, I'll tell you the way I look at it as a systems problem. There are two things in our health system that save money. Number one is generic drugs. And that used to be number one. And now with these arbitrages and syndicates that purchase these groups and put them out of business, I'm not sure if that's still number one or not. Maybe it is. But the number two thing is the primary care workforce. And I'm talking about traditional primary care. The problem that you have is you're asking those people to do, again, I don't want to try to belabor this too much, but we discussed it at length last time. You're asking them to do a number of jobs. Almost all the quality measures are falling on their heads. So when someone goes to see a physician for something else, they either have little or no quality measures that they're measuring, and we're measuring a number of these. Besides, we're doing preventive medicine. Besides, we're doing acute care. Besides, we're doing the damn chronic disease care, okay? And the problem is, it is a metaphysical impossibility for the Commonwealth or anybody else to get to a sustainable health system without a primary care workforce, because they are the people that really do the chronic disease care. It is not the specialist, okay? And I've done that work as a specialist. I'm speaking on both sides of the coin here. Primary care, in my opinion, is the only healthcare component that when you actually increase the supply, you get better outcomes. And Barbara Starfield showed us that. And the reason is you have to get your mind away from the fact that when you increase supply, you're not just seeing them for cough and cold, and I'm seeing more of them. You're seeing them because people have so many problems here in the Commonwealth that, like in my office, we simply cannot do it all. I mean, every patient would be, 90% of my patients would be level 5s. It would be crazy. But they can come in for diabetes, hypertension, dyslipidemia. Then you've got to get out to the next person who's in there for, they cut their arm. Well, okay. Then you get to the next person. Well, now we have COPD, and I'm going to try to throw in some reflux and maybe restless legs while I've got them here in front of me. Then, I got to bring them back for something else. And I just want DMS to understand that we can't deal with all of this primary care burden because these people don't have one diagnosis, 2 or 3 diagnoses. They have 8, 9, sometimes 10 diagnoses. Some of them are interrelated, some of them are not. And so the problem that we're having here is we're just not sustainable. Now, I don't want to foreshadow our work here in just a minute, but to Dr. Neal's point, how do we get to value-based care if you can't make the system sustainable? Because for every patient we see for Medicaid, we're losing money. Now, just let that set in for a second. If I told you to come to work and you worked 3 hours and you had to pay money back to the Commonwealth for coming to work, you would lose your minds. You become apoplectic. And that's what's happening here. Every time a physician provider sees a patient in Kentucky, there's just no way they're going to be sustainable. It's not going to happen. You're paying 2/3 of Medicare to begin with. And so what I'm telling you is when you're dealing specifically with primary care and quality, the existential crisis we're coming to is you're asking us to do all these things. Like I said, you want acute care from us. Okay. You want some chronic disease care. Okay. You want us to report these quality measures. Okay. And you want us to be on time. You want us to see them the same day because you don't want them in the urgent clinic or the ER. You asking us to do all these things and it's impossible. And you should darn well know it's impossible. So no matter how many words you write on the paper, no matter how many reports you produce, it is impossible for us to do what you're asking us to do. And it's not just in Kentucky, it's throughout the entire health system. And it is driving our people away from primary care. We cannot get med students to go into primary care. It's moving the burden to, again, physician extenders that are not as well trained. And we know this because of the work of recently Hattiesburg. We know this because of the work of Kaiser Permanente. I just don't know what the Commonwealth in their wisdom, I'm not sure what the end game for them really is, or for the MCOs. I'm not sure how they see this working out, but it doesn't look like this quality thing is going to work out for us. And Dr. Neal, you chime in on this really. Again, I like to pitch it back to you, but you've discussed this. What is the sustainable method that we can actually do the work here so that we can save money? Again, I want to say my last piece here would be that primary care in our health system is the only component that you can increase supply and get better outcomes. Nothing else provides that. That is the real exception to the rule. Dr. Neal?
Yes, I want them to understand that what you've talked about now and we talked about last time, that the primary care workforce is deteriorating rapidly. And we're depending more on nurse practitioners, bless their hearts. I've trained them for 30 years and I understand, but they need doctors to guide them through. I'm multitasking as we speak, reviewing nurse practitioner charts for a group that I work for. And we're maybe the only ones that do it, but we realize that it puts stress on them when they don't even have time to ask their supervising physicians, and they don't like that word. So shall I say collaborating physicians. But Medicaid needs to understand that this workforce, as Chuck says, is disappearing. We're not even filling residencies. So we've got to think differently. I'd like to, Chuck, real quickly, just read what they said. In addition, DMS will work with MCOs to develop innovative value-based models aimed at transitioning from a reimbursement model that rewards providers based on volume to a model that aligns payment incentives with quality, performance, and outcomes. Further, DMS will pursue additional managed care system reforms aimed at improving the efficiency of responsiveness to the current managed care delivery system. Well, all of that theoretically sounds good, but they're living in a different reality from the one that we're living in, Chuck. And I just think that we've got to get that through. Would somebody else like to comment on it? Angie, would you like to comment? Because we value your opinion.
Well, it looks like Dr. Tran has his hand up, so I'll let him speak first before I address some of your.
Sure. Okay.
Thank
Dr.
you.
Tran? Yeah.
I completely concur with Dr. Neal and Dr. Thornberry's comments, particularly Dr. Thornberry's comments regarding the need for primary care. I am not a primary care provider, but I clearly recognize the importance. And I also recognize what Dr. Thornberry stated earlier in regards to the multiple issues that they have to address in terms of the acute care, the chronicity of care, and of course, all these metrics. Now, I do want to say something about quality metrics, and that is one of the issues. 1 second, this must be. All right, I'll make sure that's not my buzzing in the background. One of the things that I am very distressed about is when systems are introducing these quality of care metrics, nobody takes into consideration the FTEs and the amount of manpower it takes to collect the data for these quality metrics. And when all is said and done, we spend more time gathering the data instead of doing the work that's needed. Secondly, and I think this goes back to what Dr. Thornberry stated earlier, and that is, I wish that there was a mechanism by which the physicians can be compensated for the quality of work. Let me give you an example. When I practice addiction medicine at the clinic, there are many comorbidities. We're all aware of them. These patients have psychiatric comorbidities, they have medical comorbidities, and they have Hep C. None of these things are issues that we can really take the time to address simply because it's very time consuming. It is tough enough to manage their acute problem. So a patient comes in, it takes us the full 15 to 20 minutes to manage their acute SUD, substance use disorder problem. And if we want to tackle the Hep C, or we want to tackle the hypertension, the diabetes, or whatever, we're not going to have the time. And we find ourselves having to schedule these people back for another visit so that these things specifically could be addressed. And I'm hoping that that DMS, or whoever is going to be a think tank, can look at primary care in a similar model and say, hey, we know that these people come with multiple issues, and it should probably be more patient-centric if we can address most of them at the same time instead of having them come back multiple visits. And so I concur with Dr. Neil when he said that our physicians are not just mass producing widgets for the sakes of earning income. We have patients that are waiting in line. In our clinic, we have, I think, 200 patients waiting to be seen for psychiatric, and we have probably 50 plus patients waiting to be seen for Hep C treatment. We just don't have the time of day to do this. And it would be much more expedient if we could try to take care of multiple issues at the same time and get reimbursed for it. Now, having said that, like Dr. Thornberry said, we need to be cognizant of the needs of the MCO. And I really think that when you look at a clinic and you see that someone's spending 5 minutes or less with a patient, I can't imagine how anything can get done in 5 minutes or less. And so I think that we do need some mechanism to mitigate the better reimbursements. But by the same token, most of us physicians are honestly just trying to optimize the patient experience. And there are multiple times where I just don't have the heart to let the patient go without addressing these other issues that they have. And when all is said and done, I am spending way more time than I need to with the patient, and I'm not getting reimbursed for it. There are many physicians, if you ask, who fall into that situation. So thank you for the time.
Thanks, Dr. Tran. Before you take all this, and world hunger too, just throw that in there. Listen, we want to welcome Dr. Gupta Ashima. I saw you come in. I want to welcome you. Angie, just take your time here, okay?
Well, I mean, obviously you all have very valid points and understanding, and I think we can all agree the healthcare system is broken. And there's been a lot of people, very smart people, smarter than me, that have tried to figure this all out. But I want to address, because I can go on and on myself, and having been in the business for a long time. But I want to kind of address what Dr. Neal had brought up, and regarding not enough interviews. We did ask all of our TAC and chiefs and all the MAC members if they wanted to be interviewed. And some of them we did not hear back from, or they just weren't able to work through getting a time set up. But we did have a lot of, and I think when reading the quality strategy, you can see that we heard a lot of the same issues, access to care, and being one of the main ones, reimbursement, those types of things. But certainly, as far as any additional information, Dr. Neal, you would like to provide, we certainly can hear that. This is in the getting ready to be submitted to CMS. This is also a dynamic document. I mean, just because it's not written in stone. Everything that we've put in here is, it's very lofty goals. We know that. We also know, if you read in the quality strategy, that, you know, Kentucky is 49th and 47th, 50th, and all these things. And how do we move the needle on those types of things, you know, particularly chronic diseases? Well, we got to start in preventive. We got to start preventing these things early on, and we have to start with our children. And how do we do that? But like I said, I can I can start talking, get on a roll myself on this, but understanding that we're not going to meet every one of these metrics, but we've got to start somewhere. We've got to evaluate. We've got to see where we are and how we can get, you know, a 0.5 percentage point up or improvement, or a quarter or whatever. We'll be reviewing this strategy at least quarterly, and, you know, at least and all definitely annually. We'll be working with the MCOs on this, because this is a Medicaid managed care quality strategy, which is a CMS requirement. And, you know, they all have a lot of great programs. We also do focus studies with the MCOs to kind of help drive these things to where we need to focus our energies. We have a whole division within Medicaid that is going to also be working through quality and the population health and the equity aspects of this quality strategy. It's not going to be changing today, because, you know, we've been working in managed care, since the 80s? Or no, 90s, early 90s, I think. So
Right.
it's not been fixed yet with that. I think we've made strides, but I think when you talk about chronic health, if other states are also working on these things, that doesn't help move the needle for us, because everybody else is improving. And so we stay where we are because other states are still, you know, they're doing certain things as well. So we've got to figure it out. And, you know, I worked at a regional managed care company for 20 years. And I always thought that I was going to work myself out of a job. And I never did. And because we did, primary utilization management and quality and those types of things. And it's, you know, you would think that, well, one day, they're going to get it. But technology and all this stuff changes. So again, I don't want to stray too far from what Dr. Neal is bringing up here, but we understand, you know, in the value-based contracting, we are working with the MCOs on how that can function. We want to focus on outcomes. You know, we're doing all these marvelous things, but what is the actual outcomes? We also know that, you know, each of the MCOs have great programs, but they're only getting 1% buy-in to some of the programs. So if you can't get the other 99%, what are we doing for the 1%, and what are their outcomes? There's just a lot to consider when you're developing a quality strategy, where you want, but we got to, like I said, we got to start somewhere. We would prefer to be paying for quality versus quantity, but we can't get there unless we try.
Well, Angie, first of all, I think on behalf of the committee and myself, we appreciate you personally. I really do. God love your heart's all I can say. And we appreciate the work that DMS is doing. Again, to close up this, I don't want to take all the oxygen out of the room with this one little thing, but I would just ask you, when you set your pen down at the end of the meeting, the 30,000 foot looking at the forest, not the trees, that I would try to ask you to consider, and the DMS team, is this: there is only one path for you to become sustainable in chronic disease care. There's only one. There's only one way to go, and you're going to have to go through primary care.
Mhm.
There's no way around that. And so if you can focus, every meeting that I had with my MCO partners, if I held them accountable, if you were the referee in the room, I would say, what are you doing to support your primary care workforce? And the other thing that I want you to try to please get, the fallacy that I want the people, our administrators, to get out of their mind is, you're not going to cut back your volume and increase your quality, because in primary care, It doesn't work that way. Their volume is based on a number of things. It's not just, I can see you less and get better outcomes. It's, well, sure, I can see you less for chronic disease care, but I can't see you less for the exacerbation of that, or for the acute care, or for the preventive care. And so those people are always going to be busy. And so if you think, again, what you kind of want is you really want your primary care volumes to go up. You just want them to be more efficient in what they're doing. And I think that sometimes when people get in these roles, there's a simple math equation in their mind. Well, I need to get these people seeing less patients so I can get better outcomes and spend less money. And that's really not what you want for primary care. If they're doing their job, everybody else is using less resources and they're using them more wisely. So I would just ask gently that you all consider those things. And, I don't know. Now this is a personal opinion. I don't know how you really get to that position unless you're going to go back to what Dr. Neal's pointed to. When you had a successful per member per month payment for your primary care to support what they were doing, because right now you're paying them on some type of episodic care. And really there's just things that workforce is doing that it doesn't show up in any codes. It doesn't show up in the 99213. They just, because our billing system wasn't designed around that. It was designed around surgical systems, and it kind of worked its way to the medical system from there. So again, you might want to just consider that, or the work that other people have done in this area. I'm trying to get Kentucky out of health disparities where every metric starts with a 4 or 5. And again, the only path that I see through that is through primary care. And if your primary care is going to be disparaged, or again, if you're going to move to less educated primary care, I don't see how that's ever going to be a possibility for you. It is just, to me, it's an impossibility. And I think that as a lead strategist, I would ask you to consider how you are going to solve that problem if that's the place where you're going to get all your reimbursement. Dr. Neal, did you have any other issues on the quality report? I think we've kind of hit that one enough.
Sure. Well, let me just make one final point. North Carolina has just come out with a new way to rethink Medicaid using social determinants of health. And what they're doing is they're engaging community organizations. And Angie, you may know about this because they're thinking that maybe this is something that'll work, taking some of the load off of the primary care offices and putting it into everything from Red Cross to Lord knows what. Also, the Academy of Pediatrics has been so concerned about it. They are just now appointing a panel to discuss rethinking Medicaid. And we raised this issue with Commissioner Lee last time, as you'll remember, folks, that maybe it's time we had a panel kind of like the Institute of Medicine that Dr. Emory Wilson had. Let's sit down and think of this, because just reimbursement, as Chuck said, is not going to solve the problem, because once we lost our KINPAC payments, many doors closed, and we ended up with more care being done by federally qualified health clinics, which are reimbursed in a different way. And I'm not sure we're not to the point now where increasing reimbursement for these particular items would actually affect what we're trying to do. So we really need to think about this. So I could go on, as Angie said, for a long time about it too, but I think we need to get together and rethink this. And it won't happen in most of our lifetimes, I don't think, but we need to really rethink this whole thing. So that's all I have to say on it.
Well, thank you, Dr. Tram. Ashima, do you have anything here?
Nothing to add. I agree with everything you all have said.
Yes. Well, I think we've talked about that one enough.
Well, if I can have one last word, I just want to thank you. I want to thank you, Dr. Neal, for reading it. Whether or not it took you a while, and I'm sorry it kept you sleepless at night, but I do appreciate you reading through this. And it is very important that we hear your feedback. And I certainly do understand your concerns. I just want you all to know that we, have looked at this, and we don't want you to be overburdened, and certainly appreciate what care you do provide the Medicaid population.
Well, Angie, I would say on behalf of Dr. Tran and Dr. Neal and Dr. Gupta, Dr. Linden and myself, that we appreciate that. But I want you to understand, probably maybe not like you guys, but we actually had meetings before this meeting. And so while Dr. Neal's lips are moving, we've all read the report. We all have over to my side over here, I have my paragraphs and talking points that I have to hit. So be assured that just for this one meeting that there's 5 or 6 hours that has gone in ahead of this. Please,
Thank you.
please don't think that we don't just show up. Okay.
Oh, I didn't think that, but I know Dr. Neal brought up certain points, and I do appreciate that those concerns and questions from all of you, it's understood. I just want, I'm not saying he's the only one from this TAC that read it, but
Well, there was
Thank you.
an issue on page 80 that caught my attention. I'm just going to just briefly talk about that. It talked about how nurse practitioners, our nurse practitioner colleagues, reviewing this collaborative agreement and their issue. Dr. Train can speak to this about how they're using this. I'm not sure this is a legitimate concern, but it's more of a political concern for them. Is, well, we can't provide MAT because it's not only is it hard, but now we can't find collaborative doctors to do this. Dr. Neal, did that catch your attention? Dr. Tran, did that catch your attention too?
Yes, it certainly did.
It looked like a red herring to me, but I thought since it was in the report, I thought at least I wouldn't let that one go by, because I think that's not fair-minded. I think that's more political, speak.
page 80, you said?
Yes, ma'am. I have it on page 80.
Okay, I'll look at that. I've
Well,
got it right.
the nurse practitioners have complained for years, and sometimes legitimately, that they pay for a collaborative agreement with a physician and they get no collaboration. And there's truth on both sides there. And we want to collaborate. We think that this should be a physician-led team and that we should train them constantly, just as we train constantly to keep up. And I think that's really an important point. I'm glad you made it.
Well, the politics of it, this is not the place to discuss that. We have other venues for that. But I do want you to know that I think I can speak, being in this for now 30 years, that I don't know any physicians that don't want to work as a team, that don't value every member of the team. And that's from the person that checks people in the hospital or in the front desk, to our discharge clerks, to our nurse practitioners, to our nurses and medicals. I mean, every member of our team is important. And every member has to be working properly, like any football team or basketball team, for the patient's care to be in this very complicated system where we have all these diseases and we can do all these different things to these diseases. We have all these different treatment options and how they interrelate to each other. Those variables are extraordinarily complicated. It really does take decades to try to master those things. I don't know anyone that doesn't want to work as a team. I will tell you that. But again, if I'm looking at it in a fair-minded hat, I can only tell you what the data says. And the data says, again, this year's data from Hattiesburg says that if you put physician-led teams, and this is not my data, this is CMS data based on their ACO. That ACO had an arm where they had physician-led teams versus teams that were not physician-led. There were nurse practitioners, and there was a substantial quality difference. And I don't expect you to take my word for it. I do expect you to go back and look at the document itself. But I would just, if you're going to make money that way, that's what I would say. If I'm an MCO partner and I'm in the business, I make money to provide care. I'd want to try to provide it in the most effective, cost-efficient way. And if that's telling you how to do it, why are you bothering with quality metrics? If they've really told you that they've given you the prescription, I don't know. Well, that's enough of that. Let me kind of advance this a little bit. I have another item on here, the 2023 Medicaid physician fee schedule. Cody, if you're on, you've done a lot of work on this ahead of us and with us. Would you care to speak a little bit to this? I would really like to get you involved. And I think I do have a chart for us to look at some point. I don't want to move past this, Cody, without looking at that chart.
Sure. So I guess just a little bit of context at a previous PTAC meeting, in a conversation with Commissioner Lee, the PTAC had, brought up it's kind of the 2023 physician fee schedule, and Commissioner Lee welcomed any considerations that the PTAC might have for any potential changes that the PTAC might think necessary. And so The department shared with us kind of some historical fee schedules from the past. And so in comparing those with this year's 2022 fee schedule, we looked at some of the more highly utilized primary care related codes, 99203, 99204, and then 99213 and 99214. And just in looking at the past historical fee schedule over about a 10-year period, we noticed that there hadn't been an increase or any enhancement to those codes over that period of time. And so then we kind of extrapolated it and looked at that in comparison to the Medicare reimbursement for those codes over the same time period. And so in Medicare, over that same time frame for those codes, there was roughly an 18% enhancement on the Medicare side. And then the current Medicaid payment for the same codes is roughly 66% of their Medicare counterpart. Those are kind of congregate percentages. So it's, for some of the codes, it may be higher than 66%, for others, it may be less, but that was the kind of congregate average. And so just on the Medicare side of things, I know this is Medicaid and they're separate conversations, but just for perspective, when you look at the Medicare codes, they really and truly haven't kept up with inflation. There hasn't really been much account for the CPI changes, especially as of recently. And physicians, I don't know, I can share my screen here.
Give me 1 second. I'll make you a co-host.
Okay.
You should be able to share now.
All right. Okay, can you all see that chart that I've got here?
Yeah, I've got it.
Okay, so this is Medicare, the kind of the current situation. So we see here the SNFs, outpatient, inpatient hospitals have all received enhancements to their payments on the Medicare side of things. And it's relatively kept up with the consumer price index and inflation, as well as practice cost. But down here you see the physicians, their enhanced payments have not nearly kept up with the consumer price index, nor the cost for them to do business in their practices. And so have all this here just for context that, on the Medicaid side, just for the specific primary care codes that we had looked at, it only being 66% of its Medicare counterpart, it paints an even grimmer situation and outlook than what we have here. So Dr. Thornberry, I'll turn it back over to you.
Thank you, Cody. I guess we want to try to, again, couch this in a position for DMS and our MCO colleagues to look at. This is the way I would see it as a physician and a businessman. No one in my field that I'm aware of sees a patient that has this insurance coverage to make a profit. There's only one reason to see these people, and that's because you feel called by your profession, you feel called by your mission in the community or in the Commonwealth to try to take care of these people. These are, when we talk about equity, this is what we're talking about. Equity to me is not so much a color of the skin, is can these people get access, and these are the most disadvantaged people that we have. And so every time we see a patient, we're losing money, not like most times, like every time we're losing money on this. And again, I would just implore you to consider these things. This year, if I'm not mistaken, the CPI is reportedly up about 8%. That's kind of in the world of politics because they, in the last 30 years, they've changed that metric. It's really up about 14 or 15%. Because that's the real world that they just exclude things that go up a lot. So the world that I live in, where I have to buy gas and buy milk and buy food and meat, well, that I've gone up about 15%. And on top of this, what is the Medicaid on January 1st? What's Medicare doing, Cody? Is it down? How much is it going to go? Is it down 4, 5, 6%? They're giving us a pay cut. That's,
Well,
you know,
currently, if Congress doesn't address it in the upcoming lame duck session, physicians are anticipating a 8.8% cut on Medicare.
so I'll call that 9. So 9 and 14 is about 23. So I'm looking at the first year of the loss that I'm going to take. I'm going to lose 25% more than I was last year. And I don't know if you all can get your minds around that. Again, I would say if the MCOs came into Kentucky and they lost money, well, they would just lose their minds. They would never come in. If you all came to work and the Commonwealth says, you know, we're going to give you a 25% pay cut this year, that's just the way it is. And somehow this is okay when it comes to physician doctors because they're rich and country clubbing or something. I'm not really sure I understand that. And then what's the most egregious part of this is the people that are paid the lowest, that have the lowest respect as your primary care workforce, you know, that to me is just, I don't even really have the words to adequately try to make the position, except I can only show you the data and show you how difficult it is. And I want to be forthright with you and the committee members. I am not sure we're going to be able to participate anymore, which at that point I would have to step away as chair. We're looking at this very hard with regard to our community mission. This has nothing to do with money anymore. The money is so poor on this that we're losing a substantial amount of money in my county, where a lot of people have these insurers. But at this point, we're not sure that we can stay open, to be candid with you. Our girls already don't get health insurance. A lot of these people, they work here. They can make more money in other places. They choose to work in my practice, but even I can't afford to pay them. And I may have to step aside from doing this. And I want to be truthful about that to the committee. But I'm just imploring you to consider these things, because if I'm doing it and I've stayed in this as long as I have, just to try to help Kentucky, to try to help these poor people that God put on this earth, I don't know what's going to happen to the rest of your primary care. I guess it just goes away. I mean, talk about independent primary care. Maybe if you're in a rural health clinic where you're paid on a cost basis, and instead of getting, say, $36, I get $360 to see a patient. And I don't know what world the fairy money from that comes from. Or if you work for the health system where it's $100 just to walk in the door before I can even bill you the first thing. I mean, I just find that crazy. This system is insane. It's just insane. And I'm very discouraged that our leadership has come to this position, because usually once you know, and I've talked about this before, once you understand and have insight, it's like going past the event horizon in a black hole. Once you understand you've gone too far, it is too late to get out. It takes us 10 years to train these clinicians. It takes them another 5 years to figure out what they're doing. And by the time you figured out that we don't have enough, it is way too late to fix the problem. And once we do have a serious problem, then again, I want to point to the future. We are training doctors for other states. We are purposely taking our tax money to doctors that are going to go other places to practice. They're not going to stay in Kentucky, certainly not to practice primary care. And that, again, is the only way that I see you're ever going to move your needle on chronic disease care. That is just the hard truth. And I'm sorry to have to be the guy that's presenting that to you, but I don't see any other way to tell it. I would open it up to the committee to try to see, to maybe there's somebody has a different viewpoint or a better viewpoint than I do, but I think that's just a stark reality.
Dr. Thornberry, if I may. To add to this, and maybe inaccurate, but I encounter a lot of situations where the MCOs will say that, yes, the fee schedule says it's, $50, but we only pay 60% of the fee schedule. So not only are you showing that there's a dramatic decline, but understand that when we contract with the MCOs, some of them only pay a fraction of what the fee schedule says, which seems to me kind of counterintuitive. Why have a fee schedule if everybody's going to have a different rate? The second thing that no one really has been addressing that I would really like to we're struggling many other small businesses, many small clinics are struggling because all of you are familiar, we're aware that inflation is creating a lot of havoc. The overhead costs are rising. In addition to that, the cost of labor has dramatically risen. Not too long ago, paying our staff $15 an hour was considered a fairly decent wage. Now that minimum wage is expected to be $15, nobody's going to be happy unless they're making 20 or something at the clinic because we work hard. So in light of inflation, in light of the rising cost of labor, how can we expect our small clinics and businesses to survive if reimbursement is going to be decreased? So I encourage you to think about all of these factors as we make these decisions. And I concur with Dr. Thornberry in that if we don't start taking care of the primary care docs and the doctors in Kentucky, they're all going to leave. And what good is that going to do for our population? And it goes back to, we are all trying to talk about how do we raise the bar? How do we raise the needle, the impact that it has on Kentucky citizens? If we want to improve, we need to work on chronicity, chronic pain, chronic diseases. We need to work on preventive aspects. And I would encourage people to think about how do we incorporate preventive, let's take smoking, for instance, very easy. Why can't we add a modifier, something that takes 30 seconds, a minute to do? Obviously, a smoking discussion takes a little more than 30 seconds or a minute, but just to mention it to the patient, hey, we need to stop smoking. Hey, we need to start going to follow-up care, keep your appointments so that we don't lose track of these chronic diseases. So we introduce a little preventive medicine. With every acute care, we introduce a little preventive. We introduce a little chronic disease management on there. And as a physician, you get recognized and compensated for that so that you just don't ignore it and move on. These are things that would be helpful for keeping us alive and continue to care for Kentucky citizens. Thank you.
Dr. Tran, I'm sorry, I can't figure out how to raise my hand, but I just wanted to mention that there is a CPT code for discussing smoking prevention. I don't know if you know about that.
Yes, there is, but we are having a rough time getting reimbursed. We used to force all of our doctors to, because sadly, all of our patients in my private clinic, you smoke. Well, okay, 99% of them smoke. And we made it a mandatory requirement that everybody talk to the patient about smoking cessation. And, everybody knows it takes repeat time and repetition to get it across. And we just weren't getting reimbursed for it. So people stopped doing it.
I think Dr. Tran pointed out a couple of nice things, which is you can code for it, but getting paid for it is a whole nother thing. And again, Dr. Tran, I really do appreciate your point of view. Ashima, you've been very quiet. That worries me. Would you like to say something?
No, I totally agree. I mean, I'm in private practice. I'm in, a multi-specialty ophthalmology practice. And we're facing the same thing. We have to pay all our staff $3 to $4 more now than we did before. And we see a lot of Medicaid patients, and we actually just are losing a doctor. So we're going from 3 to 2 doctors in about 2 weeks. And I was just thinking, I can't take vacation, a week of vacation till next summer, because we had to see all these patients. We had to be out. If I don't see patients, we have no income coming into the practice. And it's just really disheartening. On top of like all the no-shows, we can't do anything about these no-shows. And I did not know that reimbursement cut was going to be so high starting in January. So that's it's really depressing.
I would just mention gently to DMS that one of the considerations the leadership may want to at least put on the table at some meeting would be, I'll speak only from my head as primary care. If you think you're going to go to an MCO and dictate or negotiate what they're going to pay you, well, you were sadly mistaken. These are behemoths, and they of course know that, and we know that they know that. But the point is you might want to say, well, when we were talking about your, for example, primary care workforce, the MCOs, there's going to be a basement what you're going to pay these people, and we're going to see to it that you are going to do that. You're not going to negotiate part of your profit from that, because again, it's like saying I want to lose weight, and instead of trying to go out and diet and exercise, you're going to go out and cut your arm off and say, well, look at the numbers, I've lost weight. That just makes no sense. That's what's happening here. Is you might be able to cut your reimbursement $1 or $2 or $3 from your primary care team. Fantastic. But you're doing it to spite yourself, and your outcomes are again going to be worse. And that's something I think that the leadership would have to chat about with our MCO colleagues. I think to believe that physicians or small groups are going to be able to negotiate that, well, that's just silly talk. That's just not going to happen. Dr. Neal, do you want to get in here on this?
Well, I sent Commissioner Lee an email a couple of weeks ago suggesting, after she attended our last meeting, which we appreciated, I thanked her for that, and asked if there'd been any thought of getting us together to start having some discussions. And I have not heard back from her. I don't even know if she got my email. But I just think we have really got to do some discussions. I understand about overhead, but it was only KenPAC that kept so many of our doors open. And I keep talking about that. And the ACOs, it turns out, have not saved Medicare money. And so they're actually looking in pilot programs, which is basically a per member per month kind of thing. So I just think we really need to be some talking. And Chuck, Ashima, and Dr. Tran, I think that we all are willing to find some time to meet. We don't know enough about it, and think how our colleagues who are out there don't know anything about what's going on. That's my point.
Well, I think I can speak for the committee, and certainly as part of our partnership with the MCOs in the Commonwealth, we have tried for the last several years to extol the amount of a crisis that we observe. I think that our consciences are clear about that. I think that we've extended our hand as willing partners, not only to try to negotiate. Again, I spoke to it before the meeting began. I mean, we're negotiating as part of physicians, and I get that. It's a selfish negotiation, but I'm also negotiating on behalf of patients, because I'm the person that actually sees these people day to day and sees their lives. I'm trying to negotiate on behalf of the Commonwealth too, because I need a sustainable system where when I leave practice in a few years, I'm 60 now. Well, who's going to be the person to come up? And I don't know. I gave up looking for a partner 10 years ago. I mean, when I leave, my practice will close. Nobody's going to buy my practice. And I'm seeing less and less people do what I do. I just don't understand exactly the way the Commonwealth thinks. I know that there is a large bureaucratic system. I understand the politics behind it. I understand the money behind it. I just can't understand how they see this as going forward, unless you say, well, I'm going to be here in my job 3 years and I'm going to be gone and I'm not going to worry about this. That's what legislators do. I just don't see how you see the Commonwealth being sustainable. We're not Vermont. We just have so much chronic disease care. It is overwhelming. And we probably do what we do at the behest of the federal government, because without that money, it would be completely impossible. I just don't know the solution that you all see in your all's mind, how this is going to work out. I'm not sure what the MCOs are saying. Well, we've got this covered. Don't worry about it. I think they're going to be your friends right up until the fact that they can't make money, then they're going to leave. And they're going to say, you know what, by the way, we still leave. And if my family leaves Kentucky, well, there can be a bunch of people that aren't leaving Kentucky. And I'm at a loss for logic behind this. I don't, even if you wanted to change it tomorrow, it wouldn't happen. It would take you a year or two to get all this through the regulatory system, to get the committee people to agree to it, to pass the correct legislative changes, to get the contracts with the MCOs aligned to it. I mean, even if we want to do it today, it's going to take several years. I just think that, I don't know. I've had a peace with it. I've just decided this is something that is beyond me. I can only tell you what we see and how bad it is. And I don't know, I guess you can just believe it or not believe it, but I think there's going to be a very serious rude awakening. And then when it hits the fan, and it's going to, I don't know who's going to take the blame on this one, but I'm telling you what, this is going to be the kind of thing that every state talks about in the United States, and they're not going to want to do what we've done here. You know, Kara in Kentucky Learning was a real watermark for how to change things, and people have taken that blueprint. Well, this is going to be the inverse and direct opposite of that. It is going to be a catastrophic collapse when it does. That's my warning. Does anybody else have anything to offer on here before we move on?
Dr. Thornberry?
Yes, sir.
If I may, this is slightly off topic a little bit, but I was hoping to get an update regarding the Medicaid physician fee schedule. And this is a topic that we brought up at the meeting before. And again, I can't remember who brought it up, but it was around the discussion of every patient is given, I think, 4 level 4 codes per calendar year.
And that's been
And if
solved,
you
Dr.
exceed that
Tran.
number. Oh, thank you.
Our leadership, somebody can comment on that, but our leadership at DMS has solved that problem. I don't know if you may not be aware of that, sir.
Okay, I know that the meeting before they were talking
Yeah.
about it, and okay, I'll just get offline. Thank you.
No, and I'd like to thank the leadership for working so diligently on that. I do think that's very well appreciated.
Dr. Thornberry, I just
yes, ma'am.
wanted just to put in one plug for, what's happening next week, election day on Tuesday. If Amendment 2 passes, everything that you just said is going to exponentially get a lot worse. So, we might be having a even more serious conversation after next week if that amendment passes. I just wanted to, we don't have to discuss it. I just wanted to.
We do live in a representative democracy, and in that republic, people get to vote. And in Kentucky, there'll be no question about it if there is a direct vote on this issue. We'll just see what the people that live here want to do. Thank you, Dr. Gupta. I had a couple of points on general discussion. If it's okay, I'd like to move us to my item 6. The first thing was just, these are, I'm not sure so much discussion as information points. The first one is the issue that is kind of one of the stones in the shoe that we walk with daily, which is prior authorization. And now that continues to be a very difficult burden. We're working with Commissioner Lee specifically. We want to thank DMS and particularly the informatics division for providing us with data. We're looking at that data now so that we can speak in a fair-minded and well-informed way, and hopefully we'll have that parsed by the next meeting. But I do want everyone to know that we're looking at that. Specifically, we're looking at in the time that we did not have prior authorizations, those were waived. Was there any real change, or was there a more efficient system? It is our hypothesis that there was just a more efficient system, and we're hopeful that we'll have outcomes that will show that, but we're looking at that data. I want everyone to know that. The second information point is regarding telemedicine. I sent Cody, I think I sent you something again last night. Well, Cody, I'll let you just chime in. You've worked so hard on this. Do you want to go ahead and just get in here?
Yeah, I'll just add, a lot of the information that you shared coming out of JAMA and from the AMA, and a lot of the survey data continues to show that patients value telehealth almost as equally as they value their in-person care. Obviously, it's still a lot of surveys still showing that patients prefer in-person, but a lot of, as far as the quality and the care they're receiving online, patients have been advocating and supporting and continue to do so telehealth. So just an information point, that's just kind of what we continue to see.
Thank you, Cody. The reason I brought this up is because I want the leadership to understand that telehealth in and of itself is not a solution to anything. It's only a delivery model. When you pull up Google Maps, it gives you a walking way, it gives you a biking way, it gives you a way to get there if you're driving. And again, these issues that we're working with we wanted to know very early 10 years ago, was it safe to do it, to conduct healthcare this way? It seems to be proven over and over again to be safe. Do people like it? I think the thing last night was 95% of people like it. Probably the other 5% want it for free. I mean, but I think that what we're seeing is that this is a good delivery model. And we've invested in this in Kentucky very early on because we thought that the only way for us to efficiently deliver chronic disease care and provide some type of health equity for these disadvantaged rural populations that have geographic barriers, that have language barriers, that even have intercity transportation barriers is this. And we're seeing good outcomes. We're still monitoring, but I think the overwhelming data now in the last 2 to 3 years is demonstrating that. And I'm open again to any discussion on this, but I think that we're just looking again at this because we've invested, your physician committee's invested so much in this. We all have EMRs. Well, now we all have telemedicine systems and they cost the same thing. But I want DMS to know that we're pleased at this point with the data that we're seeing here. At this point, I would like to, if there's not been anything else, I would like to move us to the recommendation. And the chair would put forward a recommendation that to the MAC, the DMS take into account the impacts of inflation on providers as it considers the 2023 physician fee schedule and looking at enhancing and more highly the utilized efforts of primary care centered codes. Cody, you can provide that to them and to the MAC specifically. Is there is there a motion or a second on that from the chair?
Second, so moved or second.
Second, is there any discussion on this? Any further discussion?
Yeah, Dr. Thornberry,
Yes, sir.
I move to add an addendum.
Yes, sir.
In addition to your comments, I would like for the MAC and the leadership to acknowledge the fact that in addition to the inflation costs and the cost of rising labor costs, the reimbursement makes much more of an impact to many of our small clinics. And so please take those factors into consideration.
We'll take that as a friendly amendment. Is there any further discussion?
Dr. Neal, I just want to say
Yes, sir.
this. Florida approached this by giving an enhancement to primary care alone. They bumped up primary care fees for the usual office codes about 10% or so. You had to show that you were either a pediatrician or a family care physician or internist. They did it for primary care, and that helped a little bit. And that's something they might think about. They didn't increase everybody's.
Well, that's, I guess, the intent of this. The one thing that I would mention to the informatics team at DMS would be, and I think we're finding this, there's an old management saying that if you can't measure it, you can't manage it. And that may be fair or unfair, but I think the problem that we're seeing with a lot of the data is the codes that we have don't, like, it's hard in seeing the data coming through DMS. I don't know if they have things that we don't know, but we really can't tell who your primary care. When we look at these codes, we can't tell who primary care is or isn't. And that would be a big red flag, because I don't know how you can really recognize a problem or even measure a problem or administrate a solution to a problem if you don't really know who your primary care is out there. Cody, I'll let you talk about this with your colleagues offline, but we found that to be very difficult to try to help the discussion move forward when we can't get the kind of data. And I would hope that, at least if I was working in that department, I would want to understand who those people were and what they were doing so that I could at least try to intervene or measure the quality that they're giving us. But that's beside the point. There's a motion on the floor. If there's not any more discussion, I'll ask for a vote. Is there a vote to approve this to the MAC?
Yes.
Good.
Dr. Nance.
Yes. Any dissension? Without dissension, we'll move this to the MAC. Our next meeting is January 2023. I want to thank our MCO colleagues for being with us. I want to thank DMS and their leadership for being with us. And Georgine, thank you very much for making this happen for us. Okay. Okay. I'll call our meeting adjourned. Thank you, everybody. Enjoy your weekend.
Dr. Thornberry?
Yes, ma'am.
Did you want me to present this? Dr. McIntyre normally was presenting the recommendations at the
Yeah.
meeting.
if you don't mind, that would be great, Ashim. If that's not, is that too much to ask?
No, not at all.
Thank you.
Cody,
Thank
will
you,
you be
Dr.
able to
Gupta.
email me the recommendation?
Cody, can you have that
Yeah.
taken care of for?
Yeah, I'll get it typed up and I'll send it to DMS and to you, Dr. Gupta.
Thank
Okay,
you.
thanks.
Anything else, any business before the committee? With that, we'll call this adjourned. Thank you, everybody.
Thank you.
Bye-bye. See you all.
Thank you.
Have a great Friday.